My name is Ella and welcome to Goals House. I'm part of the Goals House team, so we're really glad to have you all here today. We're proud to say this is our 5th year hosting Goals House as part of the UN General Assembly and Climate Week in New York. And each year we've grown, not just in size, but also in ambition. And that's because of the urgency of the issues that we're facing and the world demands more action. At Goals House, we believe in the power of bringing a diverse range of people together to talk, to share, to find solutions, to establish partnerships, create real change with the shared purpose of tackling some of the world's most pressing issues. So thank you. Mic drop. So thank you for being here today, for being part of our community. It's been a pleasure working with Isra and Every Pregnancy and Axmed as well. And I will hand it over to Isra now to start talking about this very important discussion. So thank you again.
Thank you, Goals House. Okay, we need a bit more energy to start off the week at UNGA, everybody. UNGA 80. This is the hopefully first event for everyone in the room officially to kick off the week. And what better way to kick off this incredible week than talking about moms and babies, right? That's what I'm talking about. So excited about it. Welcome, everyone. Good afternoon, distinguished delegates, partners, and changemakers. Thank you for joining us here at this UNGA 80 side event. We have invited you here today to truly have a disruptive conversation about ensuring every pregnancy is safe. I'm Isra Shakir, CEO of Every Pregnancy, a Muslim and faith-inspired coalition dedicated to ensuring life-saving interventions reach mothers and newborns who need them most. Today's discussion is co-hosted by our partners Axmed and supported by Goals House and the Gates Foundation, which has actually supported Every Pregnancy from the very start. We've brought together an exceptional group of donors, media leaders, innovators, and maternal health champions because solving this crisis requires all of us working together differently. Before we dive into this important discussion, I'd like to ask for a quick show of hands. Which continent do you think has the highest percentage of people who give to others in need? Who here thinks it's Europe? If you're able, please raise your hand. The Americas? Asia? No one's raising their hand at all. I'm looking around. Can someone raise their hand? No one's scared. Let's start again. Europe? Okay, thank you. Our videographer, one vote there. It's great. We're already off to a great start. The Americas? Okay, I see a couple of hands. A little bit nervous about it. Asia? I see more hands, but also everyone's confused. Africa? Okay. I am so happy to announce that according to this year's World Giving Report, it is indeed Africa. 72. Let's go represent everyone in the room. I see it. Come through Nigeria. There's a big Nigeria delegation here too. 72% of people in Africa give to charity or to someone in need, far higher than here in America, which is at 56%, or in Europe, which is at 59%. And people from low and middle income countries donate a higher percentage of their annual income compared to those in high income countries. Now, I think to many of us who are kids of immigrants, children of immigrants, or immigrants ourselves, we all know that. This is not new information to us. But I want you to keep this statistic in mind during our conversation today. So why do I start here? Because the way we think about funding is still stuck in a traditional neo-colonial lens, one that overlooks indigenous communities of color, faith-based drivers of generosity, grassroots forms of giving, and new partnerships that are already reshaping what is possible. The unacceptable reality is, while we are stuck in our traditional ways of thinking and designing the means by which maternal and newborn health is funded, hundreds of thousands of preventable deaths occur each year. Every single day, hundreds of women die during pregnancy and childbirth from causes that are completely preventable. We know what works. There are proven high-impact, low-cost solutions, trained and skilled health workers, essential medicines, and simple interventions, like the plastic drape, which costs less than $1 that helps midwives quickly measure blood loss and save a woman in delivery from hemorrhage. Yet these solutions too often fail to reach women at the fault lines of crisis. Every Pregnancy was designed to disrupt this exact system. Our coalition of more than 50 organizations has demonstrated that different models are in fact effective. In a single Ramadan campaign, we mobilized over $21 million and channeled funds to frontline organizations operating over 20 countries, from Gaza to Nigeria to Pakistan and beyond, ensuring the essential care, thank you, Dr. Amina, reach the women and newborns who need it most. And this is exactly why we're here together today, embracing UNGA's theme, Better Together. Because the scale of this crisis demands that we do more and we do better work together in ways we haven't before. It mandates us to be more innovative and build more community resilience. You in this room represent the decision makers, the investors, and the implementers who can change this trajectory, but only if we collaborate different than in the past. And only if we disrupt the status quo, which is my favorite thing to do. Our panel will explore the hard questions that traditional forums often avoid. 1. What new investment models will finally close the capital gap? How can we ensure funding is used more effectively while reducing unnecessary costs? And how do we shift ownership to local actors so resources flow directly to the closest to mothers and babies, ensuring sustainable impact? Over the next hour, you'll hear from frontline implementers who will share how current funding models have supported or hindered their life-saving work. You'll also hear from funders who've pioneered new approaches to explore how alternative models can shift power, engage new investors, and direct resources to the most effective interventions. Your engagement here is crucial. You had on your chair a QR code to share your thoughts so that those outside of this room are also brought in and guided to action. Every pregnancy should be safe. That's what we believe. That no matter where a woman lives, what identity she holds, what she earns, or what crisis she is living through, including natural disaster, displacement, or genocide, today in this key place where global commitments are made, let's figure out how to make that a reality. Now let's get into our exciting panel discussion, which I am honored to moderate. It's an honor to introduce our esteemed panelists from around the world, and of course their full bios can also be found in your packet. Emmanuel Apaku, the CEO of Axmed, welcome. Alice Kanget, CEO of Beginnings Fund, welcome. Honorable Harriet Chigai, President's Advisor on Women's Rights in Kenya. Dr. Zahir Sahlul, President of Med Global and Every Pregnancy Partner. And Doris Malel, CEO of the Doris Malel Foundation in Tanzania, and also an Every Pregnancy Partner. Let's give them a round of applause, everybody. Okay, we're gonna get started with Doris. Starting with you, Doris. When we talk about improving funding for maternal newborn health, many immediately think about the fact that still only a fraction of international funding goes to local organizations. What are the barriers that you have experienced personally with accessing maternal and newborn health funding?
Thank you, Isra. Hello, everyone. The very first thing that I see as a challenge is most of funders do have a likelihood of having a trust to INGOs. So they directly give the funding to INGOs, and then the INGOs subcontract the local actors on the ground, and the local actors head down to implement the activities. So again, you give the funding to INGOs, they have a very big admin cost. So already part of the chunk of the money will go to the admin cost. These people are driving in good cars, good vehicles, they sleep in good hotels when they land to our area of work. Again, they come to subcontract the same very work that was supposed to be done by a local actor. So the INGOs work to do a reporting work. The same thing that you could have given a capacity to a local actor to implement that, and they'll give you what exactly you desire. Because at the end of the day, what I find, again, as a next challenge, apart from that, is most of call to applications, what we call call to applications. You design your idea of applications when you're sitting here in DC, New York, you name it. You don't come to design the call for applications with us, the ones who are in need of that funding. Why don't we change the way we produce our call to applications, or any kind of proposal action? Come and cook that with us. The kinds of innovations, the kind of ideas that you want as a way to fund or to support, it's a better interest that you deliver, or you create that call for proposal with the ones who are going to get the funding for it. So most of we local actors tend to say, oh, what's the next call? Was the maternal child, but what else? Or it will need PPH. So some of people who are not really going for that, they were not even planning that. The big actors already are shaping, knowing that there is something called PPH coming up. There's a funding for it. So people change their ways of doing things. So instead of really giving the funding to the person who's really desired or is really committed to those specific cause, already the big organizations are shaping up the direction so that they can receive the fund and subcontract the local actors. That's a really bad pain, and I really wish funders would they'll put money where their words are. Like, you mean to support premature babies, go directly to the local actor who's doing premature babies and donate that fund too, or support that fund too. And that's the only way you can make this work sustainable, because a local actor would continue the work, taking into consideration that is already capacitated. I was even sharing a story with a friend of mine that one of the donors came to office and said, "You're not ready to receive such kind of big amount of money." I was like, "What do you mean? Don't have capacity?" He's like, "What does capacity mean? If you give me and you trust my vision, if you trust my vision and you invest in me, I will hire the people who can deliver the job. But if I don't have a good funding to pay those people with that capacity, how will I do it?" So instead, they bring people from outside our continent to come and work with us in the name of they don't have capacities, or somebody who's coming there has capacity. But instead, they come to learn our way of work. I know how my government works. I know how the political situation of my country is. I know how to pass the laws in my country. So why would you bring somebody from outside my continent to come and teach me how to strategically support your government, how to strategically change your policies and narratives? I'm local. I know my context. I've been born and raised here. I know my member of parliament. I know my district commissioner. I know the ways to pass. I think that is the most important thing that most funders should do. They need to trust and invest in the local actors, not bring somebody from outside to come and teach us to strategically communicate, strategically change your policies and narratives. I'm the one to teach you how to do that. But just be there to support my vision, be there to understand my local context. So those are the three challenges. Most of funders don't understand the local context, so they create code proposals in their own way without connecting with us. But they're not trusting the local actors. That's the other challenge. And of course, taking consideration of everything, we still need to change the way funding is now. We need, for sustainability, you need to give to the local actors. They know how to make their work sustainable.
Perfect answer, Doris. Thank you for that. You really highlighted the ability to connect with the community on the ground. You all are indigenous to these communities. Who better to know the solutions for these communities than those from there that are connected on the ground, that can relate to the issues directly? So thank you for those brilliant insights. And that's a great way to start off this panel conversation. Dr. Zahed, over to you. As a faith-inspired humanitarian organization, what are the programs that you think funders should fund more because they deliver sustainable impact? And any examples from the field that you want to highlight?
Well, good afternoon, and thank you for choosing the perfect panel and the perfect weather.
That was all by design, clearly.
I'm a critical care specialist. This is my daytime job. Last time I was in New York and I met Isra in one of the venues, was testifying about the impact of war on my homeland, Syria. And at that time, there were chemical weapon attacks. There were people or population put under siege. There were barrel bombs. And all kinds of other things that we are familiar, you're probably familiar with the impact of war on health. And because of what happened in my homeland, and at that time I was with the Syrian American Medical Society, a group of humanitarians decided to share the lessons learned from the Syrian crisis for the rest of the world, to improve access to healthcare in disaster areas. So the mission of MediGlobal is to improve access to healthcare and reduce healthcare inequities in disaster areas and low-income communities. Over the past 7 years, we worked in more than 27 countries in the whole world, and we impacted about 30 million people. I just came back from Syria a couple of days ago, so I'm a little bit jet lagged. So I'm gonna leave the heavy lifting to my colleagues, and I'll tell you stories. So I met I visited one of the primary health centers, PHCs, in northern Syria, in an area called Al-Dana, which is near Idlib province. Al-Dana is a small city that is surrounded by IDP camps. So 50% of the patients who come to the primary health center are from the internally displaced people. And I met this amazing woman. Her name is Sausan Al-Omar. She's a midwife. She was trained by our team on how to use portable ultrasound. She's well educated. She knows the community very well because she is from the community. She's from a tribe called Shumma. And she was telling me about how is she managing pregnant women and lactating women, providing them with prenatal care, with vitamins, with checking their hemoglobin to make sure that they do not have anemia, checking their babies. They visit the clinic 4 times during the pregnancy to make sure that the baby is fine. And how is it that during the last 3 years, because we started supporting this clinic about 3 years ago, that the number of C-sections dropped in that clinic because of the education and the prenatal care and very simple measures, checking your hemoglobin, giving you vitamins, educating the family. That clinic has a model of community healthcare workers who are also paid and trained to provide education to their communities. And they are trusted because they are from the same IDP communities. So in a matter of 3 years, with very minimal resources, we were able to drop the rate of C-section from about 25% to 5% in that area. So this to me is an important thing, that small investment in communities, local communities, will improve the outcome related to pregnancies and reduce maternal death and neonatal death. We focus on training, and we focus also on solutions coming from the local communities. I don't call our organization an international NGO because in every country we work in, we have local teams that is providing care, led by local teams, and they are providing the solutions. So our role is only to support them. So even though that we have a headquarter in Chicago, but every country we have local teams who are running the show. And I think this model, where we have localization, and I know that everyone is talking about localization, where solutions coming from the local communities, care coming from the local communities, is the best model because it is cheap economically, it's sustainable, and also it's empowering the community. Now, Syria, I hope that there will not be more war, transitioned from war to post-crisis recovery. So the investment that we had during the war now is showing up in the local communities. And the other thing that I want to say, that we don't have exit strategy. Many organizations talk about exit strategy. We stay with the local community for the long term because after the war, the communities will need also support. They will need salaries, they will need training, they will need technology, and the Ministry of Health and the government will not be able to provide that. So it is important to stay with the countries that are coming out of war or disasters for the long term.
That's a really good point, Dr. Zahid. I want to give a round of applause to everybody. That was great. Dr. Zahid, something that you brought up is around the model of parachuting in for just being a Band-Aid solution to saving moms and babies' lives, but obviously can apply to other sectors. But really, it's about how you're investing on the ground up and not parachuting in, parachuting out. So I love that you lead with that. Honorable Harriet, you're the special advisor to the president of Kenya's Advisor on Women's Rights. What role have local humanitarian and community-led organizations played in your country's ability to save the lives of mothers and newborns?
Well, thank you very much. Allow me to say this, that the Kenyan government has actually done a lot in the last 3 years. And I want to marry the work that the government has done and integrate that with the local CBOs and humanitarian organizations. You find that the Kenyan government has put very robust laws on matters health. For instance, currently as we speak, all Kenyans are actually integrated in the universal health coverage. We have the Digital Health Act in place, which now allows government to protect the content, or rather the information or data around any Kenyan who's visited any hospital. And within that realm, you find that any data, for instance, GBV or maternal mortality related issues, once the kids pick that information, that data is taken care of and it's protected. And when it comes to issues to do even with GBV, the court process is shortened, because now the Digital Act is in place to protect the rights of all Kenyans. We also have the Universal Health Coverage Act, which now allows every Kenyan, the 56 million of them, to be given proper treatment whenever they get into any hospital. And then we have the Facilities Health Act in place, which now has desegregated all the health facilities in the country and given them different segments in terms of level 4, 5, 6, 7 to cater for all individuals from the grassroots up to the national level. So you find if you're pregnant and you do not have any complications, you can easily go to the nearest facility and they take care of you. So what has that done within the country? You find that we have the humanitarian organizations in place, which for a long time have been working within the ASAL regions to not only provide health care, but also other humanitarian services. So these institutions work very closely with government, and you realize with the laws in place now, each and every institution now has to plug into the dreams and wishes of government for us to be able to tap into the community as much as we can. We also have the faith-based organizations, which actually run more than 40% or near 40% of facilities in the country. With the new laws that are in place, you discover that for them to be able to actualize and work very closely within the UHC, within the legal framework of matters to do with health, they also have to integrate whatever systems they have with government for them to be able to deliver services to the community. Within that space also, you realize that government has actually put in place the community health promoters. Not only are they trained by government, but we're integrating the national government policies with the county government, health system for us to be able to reach up to the village level. So you discover that the community health promoters actually work with communities. They are well trained. As we speak right now, government has trained more than 3 million of them. 300,000 of them. For them not only to provide first aid or first-hand health care to whichever household they go to. So you find the way we've demarcated them within data up to the community level. I've just given Kenya, we have about 56 million people. By and large, we have about 19 million households. With the community health promoters, an individual can easily visit 100 homes within a month. That translates to about 3 homes every day. So it means a well-trained community health promoter can still visit 3 homes within their village setup to not only check on high blood pressure, to not only check whether there's a pregnant woman in that home and give proper advice where they can, which facility is nearer, where they can receive medical attention faster than ever. And also, they can finish the 3 households and go to other business. So with that, we actually have very good data. Like Homa Bay County, one of the counties has actually registered 0 maternal mortality in the last 3 months. And this is actually data that was given by the county governor of that region. So for us, that is a big win, because maternal mortality is our biggest headache right now, because you find there are some counties, because of the gaps within the medical system, we have been losing mothers. You go to the ASAL region, out of every 10 women who go to hospital to give birth, we are actually losing 6, either the child or the mother. So what the government has done, and working with all these institutions in place, and as I've said, the kind of legal reforms and the medical reforms that the government has put in place is very aggressive. Very aggressive because we have 5 years to deliver. So what does that mean? It's a hard push. And because of the hard push, everything must be done within a specific period of time. So you find, as we speak right now, we are also moving towards disaggregated data. Within the health system, the government, we can be able to see how many Kenyans have actually registered within the dashboard. We can actually tell within which counties how many women are now pregnant for as long as they're registered in the system. And we are also now calling on all institutions, the humanitarian organizations, faith-based organizations who actually run 40% facilities, that is a lot, to now plug and register within the government system to align with the legal reforms and the statutes that we have put in place for us then to be able to take care of all Kenyans. So it is now easier for us to see that within this region we have 1,000 pregnant women. 10 of them are actually having pregnancy-related issues. For instance, if a place like Lamu, for you to get to the nearest hospital where we use donkeys as transport, it will take the donkey 6 hours. So what does that mean? You start your journey 8 hours ahead of time. So the kind of system that the government has put in place will actually save a lot of Kenyans on matters health. And that is why now all the persons who are owning facilities or institutions who are owning facilities, be it the churches, be it the humanitarian organizations and the work that they are doing on matters to do with training, it's important that they all plug into the government system, work very closely with government so that we can achieve one goal. So for us, I think we are very happy because now as we speak, as of today, I think we have about 23 million Kenyans registered in the system. For me, that means we're almost getting there. We have about a deficit of another 26 million Kenyans to register within the Taifa Care program. And if we get all the institutions, whether faith-based organizations, humanitarian organizations, also to register with government, register the institutions within the system, then we'll all be moving towards the same direction to ensure that we safeguard not only mothers but all Kenyans within the health system. So it is a big win for us, for women and children especially, because you find that once a woman gets pregnant, you have 9 months to plan. I'm now talking about a rural woman, not the woman within CBD or the town centers, because those can easily get transport quick to hospital. Those can easily get, help. But the rural woman, I'm talking about where there's zero transportation or near no transportation. As I said, Lamu is a landlocked country. It's within the Blue Belt. Transportation was a big problem where if a woman has to cross a river where it's crocodile infested, they're in trouble. But if the government knows that we have this woman here and they're pregnant, or if the institutions around that region know that we have this woman and she's pregnant, we can plan the pregnancy for the 9 months. So that if you need to go to hospital a day before or your case is an emergency case, we're able to sort that out. So the government of Kenya is actually moving towards preventive care vis-a-vis curative. So I think that is for us a big plus, and we are happy that now all institutions are actually plugging in and they're registering their hospitals within the system.
Yeah. Congratulations to the government of Kenya and the people of Kenya. It's incredible progress. I love hearing that. Thank you, Honorable Harriet. Manuel, we know that the need to increase financing for humanitarian response is acute and significant. However, this is not the full picture. Can you tell us about what steps you have taken to unlock efficiencies at Axmed and create fiscal headroom to respond to the needs of pregnant women impacted by crisis?
Thanks very much. Can you all hear me?
Yes.
Perfect. First of all, it's great to co-host this wonderful event and to have all of you here in the room. It's such an important topic, and for quite a few reasons. You've heard all the brilliant speakers, plus the very eloquent Isra, talk about why it's so critical for us to think about and take action with regards to maternal mortality. But let me start with perhaps 3 important statistics. 30 years ago, we were 5.5 billion people on this planet. And in the 30 years since, we've added about 2.5 billion. If I ask the question, how much of those people, new, babies, children to the population, were born in parts of the world already facing the biggest challenges with access? Some people might get that question right, but I'll save you the trouble. It's 99%. 99% of the 2.5 billion people were added in low and middle income countries. In the next less than a decade, by 2030, we estimate 9 billion people. That's another billion births. And again, over 99% from the expectation of geography of people will be added in parts of the world already facing the biggest difficulties trying to get access to high quality treatment, including the MNTH population, maternal, newborn, and child health. So here's why this is so important, because you asked the question, how are we unlocking efficiencies to enable more access to high quality care? We're doing so in three ways. The first is the current system is broken. I mean, we've lived in a world where so far the idea that global health has to be expensive to be good has basically prevailed. You see the cost of going to markets or reaching new mothers and newborns, and it's through the roof. I mean, you asked the question, why is it the case that we see, an antibiotic in Austria that is 200% cheaper than the same drug in Accra? And we've done the math. I used to work at a pharma company. I was quite curious about our portfolio because I always thought, well, now that I'm in the company, big bad pharma, as people kind of like to think about pharma companies, then perhaps I can do something to change this. And we did some of the math, and we saw that a huge amount of the medicines that we manufacture, I wouldn't name, I'm sure you can look at my LinkedIn profile, but I wouldn't call any names here. But a huge amount of the medicines that we make were actually more expensive in parts of the world already struggling. And this was a bit of a shock to us because, why is that? Why can't we get these medicines in at the same price as they are in the wealthier parts of the world? And the reason was because in the wealthier parts of the world, you have economies of scale. Economies of scale kick in. Individual reimbursement, scale reimbursement, collective purchasing, group purchasing, large scale, very attractive opportunities for high quality players to go to market. In the growth world, you have a very fragmented ecosystem. Across that ecosystem, whether it's how you think about commercial or regulatory or financing, you find that intermediaries take up those gaps because pharma companies are not establishing a presence in those markets. And the average markup of a high quality maternal, newborn, and child health product on the therapeutic side, medicines, is between 200% and 500%. On the consumables, you talked about drapes earlier, you see markups between 40 and 60% in parts of the world that simply are already struggling. So we asked the question, in a universe where technology has changed the game, where we can introduce this kind of monopsony power, enabling the buy side, the buyers, to essentially grow and build scale and make themselves very attractive so that competition kicks in and high quality suppliers, and in our case, manufacturers, see those markets as an attractive value proposition. They want to go to those markets because they can make return in those markets, and they can do so because the volumes are quite high and we can reduce that fragmentation, which introduces cost. And that's exactly what we've been doing at Axmed. We've built a medicines and consumables marketplace that allows buyers to essentially aggregate their demand, introduce scale, and the results have been astonishing. We've seen, especially in the maternal, newborn, and child health work that we've been doing with the Gates Foundation and others, we've seen a significant decline in cost for commodities that are life-saving. And we think that, I saw, it says here climate week, and climate change is very, very important. But I would argue, perhaps somewhat controversially, that the first impact of climate change is on health. And the most vulnerable population are the ones who today can't do anything to fend for themselves at scale. Newborn babies they don't have a choice as to where they're born. Pregnant mothers are already very vulnerable. And the idea that there are those who would take advantage of this kind of value chain asymmetry to generate unthinkable profits at the expense of lives is something that we simply could not countenance. So it is incredibly important that as we go about thinking about ways to make it more effective and more efficient to go to market, we do so by, I would say, partially dropping the kind of, prehistoric models that have governed how, access to high quality commodities has been run so far. There needs to be a robust rethink. We see the ecosystem across the world. I mean, it's not news to anyone in the room that the funding landscape has shifted dramatically. The era of fast and loose capital that was kind of seen as supporting health systems, but in some cases were foreign policy levers, has now changed. And governments across these markets are now taking more responsibility for their own populations. And they're saying, well, we don't want to just rely on the generosity, as incredible as it was, of external donors. We want to find ways to also participate in that process. And the best way for us to do that is to make ourselves as attractive as possible for the best quality medicines to come to us. So we believe in this. We think it's incredibly important. This is the right time to do it, and this conversation has never been more timely. So thank you so much, Israel, for coordinating all this incredibly well, and thank you to everyone for being here.
Thank you, Axmed. I would go on to argue that you are the best marketplace for medicines in the world, and we are very grateful that Axmed is into this universe and continue to support them. And we are really happy, as every pregnancy, all of our partners are actually onboarded onto the Axmed platform. So what you're looking at is not just partnership for the sake of UNGA. It actually is partnership for the sake of the long run, where we're trying to save as many moms and babies' lives globally together. So we're grateful for that. Alice, last but not least, and I have to give Alice a huge shout out. She got off a plane from Nairobi like 3 hours ago, so she's here and hopefully is not suffering from jet lag too much. But you get to round us off before we open it up to the audience. Alice from the Beginnings Fund, what are your recommendations for how funders, implementers, and innovators can work together to ensure services, including essential medicines and products, reach the most at-risk mothers and newborns, and building resilient funding models so that when, for example, a funder like USAID gets shut down, funding for maternal and newborn health doesn't stop?
Thank you, Isra, and thanks to you and Emmanuel for convening us here on this very important topic. I met with a government leader the other day, and they said to me, I think we're spending too much money for very little impact. For all the emergency obstetric care training that has been done, especially in countries on the African continent, something should have shifted. So what do we need to do differently? The Beginnings Fund is a new philanthropic initiative that is focused on accelerating reductions in maternal and newborn mortality. I say accelerating because we recognize there are others who have gone before us, governments, funders, who have done a lot of work in laying the ground. But at the current rate of reduction, we will not reach strategic development goals. I think there are a few countries like Tanzania that are really bullish and daring to get there. But by and large, we are not on track to reach our goals. And one thing I think, Isra, that I want to address before I get to the real question, because I was really moved by Doris's comments around how funding is being deployed. Beginnings Fund in itself has tried to take a different approach by even how the funding is coalesced. It has brought together funders from the Middle East, funders from the Global South, and funders from the Global North. As you know, the anchor funders are Mohammed bin Zayed Foundation for Humanity from the Middle East, Delta Philanthropies from the Global South, Zimbabwe. Then we have funders from the Global North. Gates Foundation is one of them, ELMA, and the Children's Investment Fund Foundation. Beginnings Fund has also taken a very deliberate approach to be African-led, and the team that I lead is largely African and based on the continent, and also to really look at funding African-based and African-led initiative by design. So it's not a localization agenda. It is by design from the onset that we would work with partners who have context, who are grounded on the continent, and who are there to stay. How should we think about funding going forward? First of all, we should acknowledge progress. Before the seismic shift, I would call it, earlier this year, we were making progress. We had cut maternal mortality by half as a global community. Unfortunately, the African continent still bears a huge burden, but there was movement. But now we are at least a very huge risk of losing that progress. I would say one of the things we should learn, back to the comment from the government leader, is we just have to make the money go further. We have to do things differently. We cannot be investing billions in training and not seeing impact. And we have to think about, are there different approaches, innovative approaches? What is the place of technology in delivering or in implementing, so that we're not spending too much money for very little impact? I think we also have to look at what has worked and amplify what has worked. Whether it is in community approaches, I was particularly moved by this example from Syria. That again, it's not about really putting big dollars behind initiatives, it's how we execute them, and it's the partners that we use to execute. So whatever is working, we must amplify and recognize that sometimes it's actually more the software than the hardware. Yes, we need to invest in tools and technologies, but what the example you gave from Syria tells me that also the leadership, the communities themselves, making sure you're tracking the pregnant women can really drive big change. I think that we would like to see more philanthropists come into this space. We can never replace, and I will be honest here, the depth and breadth of government, both national governments that we're seeking to partner with, but also like the funding that was coming from USAID. That being said, I think philanthropy has a place to play in catalyzing capital, in investing in catalytic investments that then attract additional funding. So the Beginnings Fund is one such initiative, and I hope more and more others will step up, so that this progress that we've had over the last decade is not lost. And as you said, every woman should have a chance to a safe pregnancy. And lastly, I'd like to say that we do not recognize the role of our partner governments. Philanthropic capital would not be able to be deployed if governments have not laid the foundation in health facilities, in health workforce, in supply chain systems that then we come and plug in to be able to improve the care. So continuing to urge our governments. I know the fiscal space, like on the African continent, is really tight, but we see governments continuing to invest because they understand the importance of investing in maternal and newborn mortality. So one of the things we're doing as Beginnings Fund, for example, is using this opportunity to push for additional financing. Now that there's this catalytic philanthropic capital coming to support maternal and newborn health, what more can government do to drive the agenda? So we need to recognize that the individual countries also can allocate more if they see that there's movement, or galvanize matching funds if there are others who are willing to come and co-invest along them. We must amplify what is working, we must recognize the role of governments, and I would argue look at new funding models like the philanthropic initiatives that also seeks to defragment funding. One other last tidbit from another government leader is they told me, I don't want to see franchising, which is what Doris was alluding to earlier. So where money moves through so many layers, and in each layer we're losing funding. How about we who are able to support or who have funding, stop the fragmentation, defragmentize, and pool our funding together such that we're not losing funding in administrative costs. Thank you.
Absolutely, Alex, so many gems that you just dropped. I mean, everyone on this panel, this has been incredible, but I think you brought up a really good point about co-funding model and using investments as catalytic funding to boost the work the governments are doing, but also what the nonprofit space is doing, and especially local actors leading the way. So I appreciate that. I know our panels have more to say, but I want to open it up to the audience. If anyone has any questions they would like to ask, if you could raise your hand, we'll get a mic over to you for these incredible panelists. I know people have a lot of thoughts, so we have a question in the back, and if we could just keep comments and questions brief, that would be great. Gabriel, if you don't mind running a mic back for us.
Maybe I can just speak. Can you speak me?
No, I think Marlene, there's a mic right here, Ella. Sorry. Perfect, thank you. Teamwork. Love to see it.
Hello, thank you so much. Can you hear me? Okay. Hi, thank you so much for this wonderful panel. And I guess I've been really focusing on global health financing. So a lot of the good points you talk about really resonate with me very, very well. And I guess kind of resources integration and how to really mobilize the private funding to galvanize the government really coming in so as to really ensure the sustainability. I think that's a kind of the thing we have been thinking a lot. And I guess one of the questions I have over here is that maternal newborn children kind of healthcare delivery platform, I actually see kind of good potential so as to deliver more impact beyond that, right? Because we have a lot of, this kind of very good touching point for the baby or just for kind of people that can be institutionalized into the government public health care system, which is care delivery chain down the road throughout the whole lifeline. So I guess question I have is, can we potentially thinking about integration of the maternal newborn children health platform for other disease area? I know what we talked about in this year for UNGA is NCD, right? So can we kind of also think a little bit more beyond just focusing on that and just go beyond so as we have more other care delivery needs also being tackled by just really lacking on this platform. So thank you so much.
That's a great question. And while our panelists think about who wants to take that, are there any other questions we can pull? It's over to Ismail, who's actually a big Bitcoin investor.
Get kicked out now.
No, not at all. We love to talk about new ways of financing. Bitcoin, come through. Go ahead, Ismail.
My question, thanks for the whole panel, but my question's to Emmanuel. I really appreciated your points. So from what I understand from kind of your position is that a lot of the issues are the economies of scale and the weak local trade. I was just wondering what the role of collapsing currencies is in making it more expensive by 200, 500%.
Do you want to share a little bit about your platform, Evergive? Because I think this is good context for the audience too.
Yeah, sorry. The main reason why I was interested in kind of collapsing currencies is because I feel like what makes it unaffordable is the asymmetry and where medicine can be held to kind of the global asymmetry and monetary asymmetry. And so with Evergive, we are, thanks so much as well. So with Evergive, we are a Bitcoin reserve for charity. So we're very interested in making kind of these areas of the world economically sovereign through Bitcoin and helping them opt out of a system that might not have been designed economically to uplift them. So a lot of the points that Alice was mentioning about how to make sure that there's less kind of layers in between all of the various kind of levels of funding. The areas where it's difficult to get money to makes it Bitcoin makes it accessible, and I can go on about Bitcoin, but
thanks, Ismail. I'll pass it to maybe Emmanuel first, and then we'll open up the panel for the second question, or the first question.
Right. So I think it's an incredibly astute point. I think partially because whilst the fragmentation creates economic disincentives, the reality is most big players today who go to markets have to hedge for currency. And let's take the Naira for example. One day it's X, and another day it's Y. I've got a lot of my Nigerian brothers and sisters.
I see the head shakes. We got feelings and thoughts over here.
And it could be as swift as from one day to the next. A product that costs $400,000, let's say $1,000 to make it sort of conceptually, the next day could cost double that for those who are paying in local currency. And so they have to deal with the double challenge of fragmentation creating disincentives and a lack of economies of scale, and the currency challenge, because yesterday they could afford this drug and today they can't. And a huge part of what could solve that, I think, has to be government intervention. There needs to be a very clear roadmap on how to keep currency stable. this is obviously tied to local economics, which take a lot of time to manifest in terms of decisions being made today. But I do think that there's a role to play, by governments to unlock how currency moves within the continent. We have an example of this. We have examples where we're trying to support a particular client with, a shipment, and that client cannot pay us in US dollars because they have to go to the central bank, and there's a lot of, monetary controls that the central bank has put in place, making it difficult to make payments. So they then have to pay us in local currency. We then have to think about what it takes for that payment to be received in a local currency, knowing how quickly the currency fluctuates and how volatile it is. We have to make arrangements for that payment to be made to our Naira account in another country, in Kenya, for example, and then take a spot rate agreement in that country and convert that local currency to US dollars. None of this should be the case. None of this should be the case if you're trying to move at speed to get commodities to people who need it the most. The one advantage that we have once you introduce scale economics is you can already deliver product at a significantly better price, which has a massaging effect on the currency volatility. It doesn't make it okay, but it reduces the potential pain that could cause. Very often, so for transparency's sake, we've said, if the markup from factory to facility or pharmacy is up to 500% today, and that's being very conservative. I've done the same comparison on oncology drugs, and it's 1,500. Then we could take a maximum 10% margin on that, which is 400 whatever times less than what the prevailing rate is. We made a public commitment to cap at 10%, right? But we said up to 10%. What that means is very often we actually will take a hit on our operational sustainability to make it more accessible from a price points perspective. But you're right. I mean, to run a sustainable business that doesn't rely purely on charitable funding is not sustainable with that model forever. We have to find ways to hedge this risk ourselves. I think we're doing a great job of this, but it's a real concern. So if you have a platform that uses cryptocurrency or other models to really sort of help support this, we'd be very interested in learning more.
Orgive.com. Okay, shout out to you, Ismail. Thank you for being here. I wanted the first question, if anyone has an answer to that, but I also wanted to see, I know in time we want to give some time to the audience to also socialize and get to know each other. And we have a couple more remarks coming up that I want to introduce. But is there any last words about disruption in the maternal newborn health space that our panelists all want to share that they haven't already shared or the audience hasn't heard today? Maybe start with you, Doris, and then if anyone wants to answer that question as well, that'd be great.
Thank you, Isra. I want to share a bit of a story. I think it will really help donors, friends to understand what it means to continue supporting acceleration of maternal child health. Well, echoing what Alice was talking about, I feel like on maternal and child health, as far as funding is concerned, somehow, some way we have really kept the funding back down. I feel like we need to add more support to it, especially on policy and advocacy. What do I mean? So hear my story. So back in 2020 and 2017, the Doris Small Foundation got really tired of donating equipment to hospitals in my country. So then we said, why don't we get the government to do this? Because by then, when you knock different doors, they're like, yes, premature babies, but we have other challenges that we need to really put an eye on. So what happened to us? So we decided to take a very big push of policy and advocacy, and we decided to ask few funders to support us on that. And what we did is to sit down with the government and push them to budget explicit for premature babies. It wasn't easy. It was meeting with ministers, permanent secretaries, write letters to the president, you name it. Like, it took us 5 years. But in 2022, we made sure and we got the limestone, and the government budgeted for premature babies explicit. So now as we talk in our country, the government itself is donating equipment on its own. Philanthropic donors now, since they know that the government priorities on small and sick newborn babies, they are naturally keeping the funds on that side. But also we've managed to amend the parental leave law. Again, that's a work of what the foundation has done. So I feel like somehow, some way, the government or actors need to be told what's happening on ground by local actors. And most funders are not funding policy and advocacy to some extent, because they feel, yeah, it's just words, but words are the ones who tell the decision makers, this is what is happening in Uganda, you need to put money here. So if we're looking for much work, much funding, much financing, you need to put the government to invest in A and B. You need to do that. The last example that I would give for a funder who really understood the assignment, keep a child alive. It's Ali Sheikhi's organization. So they found us on ground, and they asked me, Doris, what's your vision? What's your dream? I said, I want to build the first neonatal care unit in Tanzania, a first standard. They said, okay, how much does it cost? I said, 600K. I said, okay, we'll fund that.
Amazing.
So simple like that. But they said, what about the staffing? I said, yeah, that's a good question. How am I going to get the staffing? So I went to speak to the government. Of course, it took a lot of efforts. But again, because I'm an advocate and I'm known to make a lot of noise on premature babies, the government said, so what's on your table? I said, we have 600,000 building ready to be built by KCA. Can you put staffing? They said, oh yes, that's what we want. If we have more actors who can match our efforts, we are ready for that. So I feel like the governments are ready to match, but who's telling them? Who's being facilitated to tell them? It's a lot of work. The same goes to what happened to last one, to World Prematurity Day. I'm just giving an example on what it means to support the little funding on policy and advocacy, like the pushers, the actors. I went to meet Dr. Tedros, the Director General for WHO, and I told Dr. Tedros, we need a day to commemorate for small and sick newborn babies. I said, so what will that mean? All countries will start discussing the challenges. They'll start discussing on what can we do. Donors will say, so what can we invest in? And those were the discussions. So that was last year, and this year, the day the resolution was passed. It was just an action of one local actor who took a plane from Tanzania to Swiss, made a discussion with Dr. Tedros. We were told what to do, and then here we are. We have the day, but it's the work of a local actor. So we need to support such kind of movements. Who will change the world? Who will not just talk about Kenya or Tanzania? We'll talk about the world, the African continent. So we also need to look at those. Can we get little actors who can go and disrupt tables and say, we need money on this angle?
Everyone here is a little actor right here. They're all signing up. We're all telling them what to do. It's amazing, Doris. Congratulations.
So I said, let me just put that on table. I won't feel good leaving this table without sharing such good ways to continue supporting acceleration and much support of our initiatives in our context.
We love that. We want all of our speakers to really good leaving this session with 3DUI's concrete, tangible takeaways. Over to you, Dr. Zahed.
So a couple of things. So 2.5 years ago, we started Every Pregnancy initiative, and at that time, we did not expect what to happen. But we were creative, and you were creative, and tapped into donors, which we usually don't tap into it, which is the Muslim donors, and linking zakat to saving lives. Because traditionally, zakat money, which is a mandatory donation that Muslims should donate every year, is linked to saving lives through food. But linking it to saving life through maternal health is something that is innovative, and it succeeded, and large part to you, Isra. So let's give Isra a round of applause. I don't know how many lives were saved because of this initiative, but we have to be creative and linking these issues, saving lives, to mandatory zakat or tithe or other mandatories. And also the fact that organizations should not be judged only on the impact of their work on the field, but the diversification of their donors. So some organizations have stopped working just because the United States of America stopped funding them. So we have to require organizations to be agile and diversify their funding. That means they have to have faithfully groups that donating. Muslims, Christians, Jews, Buddhists, people of other faith donating. So that way, if a government stop funding, they will continue to fund their life-saving measures through other means. The last thing you mentioned, disruption. In Yemen and Gaza, we have two creative programs. In Yemen, we started women-friendly clinic. Yemen, by the way, is a huge country. Every area is different than other countries. We talk about localization in the context of countries, but every country have different localities. So Aden is different than Sana'a, different than Taz, different than Hadramaut. So, and Yemen has many villages. So if you want to save lives of pregnant women in certain villages, you have to depend on midwives. So we created a program, a clinic that is run by midwife. We trained the midwives on portable ultrasound. We provided them with portable ultrasound, and the midwife's house became the clinic. So that way there's no running cost. And then this is sustainable program. You just train, you provide ultrasound medical supplies, and this is sustainable program. We started by 20 clinics, and we hope that to expand that to 500 clinics to cover all Yemen. In Gaza, we started in 2019, and we're talking about technology and adaptable technology. Adaptable and effective technology does not mean to be expensive technology. So portable ultrasound, very small device. You connect to your smartphone, and your smartphone becomes a Doppler screen. So we train critical care specialists and emergency room physicians on the use of portable ultrasound. We donated many portable ultrasound to many hospitals. During this war, I went to Gaza last year. Every emergency room physician, every critical care specialist is using portable ultrasound. So these type of technologies save many lives, and we have to talk about these issues. The last thing is how we can learn in the context from Kenya, a great example, and Tanzania, countries that succeeded in incorporating NGOs with government policies to save lives. Syria right now can learn from Kenya, can learn from Tanzania, and how can you share these best models with the government of Syria, so that way they don't go through the same mistakes that probably other governments went through.
Thank you so much, Dr. Zahid. I am getting the clear direction from the Goals House team that we have to wrap up, and we will wrap up in 5 minutes. The last session, I want to get to this incredible panel. Let's give them all one final round of applause, everybody. There's never enough time, and I don't like being a moderator that stops this amazing vibe and energy. I want to introduce someone very special in the audience to give some reflections to us. Among the amazing group, we are particularly grateful to Dr. Sanjana Bardwaj, Deputy Director at the Gates Foundation, who was the catalytic funder for every pregnancy and believed in my vision and supported our work and got us to where we are. Without her, we would not be here. Dr. Sanjana, please share some remarks with us.
Thanks very much, Isra, and it was totally a team effort. I think, not me alone, but good evening, everyone. Such a pleasure to be here today. Very inspiring discussion. I just want to thank the team, the co-hosts, Axmed, Emmanuel, team, and Isra, every pregnancy, to really co-host us and start us off, kick us off in the UNGA week, as we call it, with this very energizing, motivating discussion. And of course, thanks to the panelists. It's as I was sitting there and furiously taking notes, I was like, wow, this is a great group. It really brings out some very clear sort of thought processes and ideas and actions to take us forward. And I'm sure everyone agrees with me in the audience, right? So some of the things that came to my mind, and maybe to summarize in 3 things. One is we need to reimagine. 2 is to rethink. And 3 is to reinforce. And why am I saying that? So reimagine, really, I mean, we heard this from our panelists, but reimagining the funding models we have. I mean, there was a lot of good examples shared here. There's a lot of energy today in the world in really trying to understand what funding models work, for whom are they trying to work, and how can we make them work for the sustainable future. And I think the opportunity we have today is unique, and we can see some of that happening here. It can be magic if the catalytic sort of co-funding, the match, different things that were discussed today can actually come together to, I know, a vision that is shared by many of us that have gathered here. Also see the reimagining of systems. How do you invest in systems from a long-term viewpoint? Now, I know many of us who've been working in this, systems has always been the word that, gets interpreted in different ways. We all have different definitions for it. But the core bottom of what we're trying to do is really make something so strong and sustainable and reaching everyone, especially the most vulnerable, is not, you know, I think we share that when we talk of systems, whichever angle we may come from. And I think here is an opportunity to reimagine this in today's world. For rethinking, I would say, I mean, lots of thoughts there, but I would agree with so many of the points made. My work in public health has been on the field, and I've spent so much time at the country level, and I couldn't agree more that the local leadership and the local solutions are the way to go. We know it, and so I think everyone, I see a lot of nods and everyone agrees. I think we just need to figure out how to make that happen and continuously reinforce, which brings me to the point of reinforcement in terms of the mission, the collective mission we all share. And I know I represent the foundation, and the Gates Foundation is committed to its 20-year vision to end preventable deaths for mothers and children, which is such an empowering sort of vision to look at. We are energized by it. We are grateful for all the partners in the room. There are many of the partners here today that are doing immense work with the foundation. And I know we share that vision and that sort of mission to really make that change and make it, and never have to work with and talk about the deaths of mothers and babies. It just shouldn't happen. And so I think I would like to sort of keep us with that pot of reimagining, rethinking, and reinforcing as we close out this session, but just the start of a sort of a very intense week of the United Nations General Assembly. And I know everyone will be hopefully seeing each other in many other sessions as well, and need to step up our energy as we go forward. But let's all commit to translate intent to action. I mean, a lot of us have been working on this for so long. The intent is very much there. What can we do and continue doing to translate that intent to action? The sense of urgency is definitely there. I know we've had so many discussions, myself and Isra, but many of you in the room. You know, as we were talking, it's been 60 minutes, and if you look at the statistics, we've lost 30 pregnant women somewhere in the world in just this last 1 hour. Sobering thought, something that I know we are all very, very concerned about, and want to do whatever we can to change that. We've heard some of that today, and I do believe every journey, every win starts with a small step. We've taken several steps today in this panel discussion, and I know we'll continue to take those steps as we go forward together with the collective mission of making sure every pregnancy is safe for every mother, every baby, everywhere. Thank you.
Thank you, Dr. Sanjana. Beautiful reflections for all of us. And before I pass it to our speaker to close us out with the last remarks, I want to introduce Tayo in 1 second. I just want to remind everybody to stay in touch with Axmed and Every Pregnancy. Follow us on socials. Every Pregnancy is launching a podcast called Born Into early October, where you can hear conversations with Manuel and Doris and myself for an hour long each, which is going to be amazing if you want to know a lot more about us. But it's an amazing podcast to help change the narrative and build the salience that we're all collectively building in this ecosystem. And with that, closing it off to Tayo, Eric Bogbo, the Global Head of Corporate and Public Affairs at Axmed. Bring it home, Tayo.
We really feel like put a spotlight on that. I just want to thank everyone for joining us here today. It's been incredible. Thank you again to all the speakers. I guess to close us out, really what I want to say is, what next? We wanted this to be more than just a talking shop, but we wanted to be about some action. So coming out of this, we actually have a call to action. We'd like to also hear from you in terms of what you've heard here today, whether you have further contributions to this. But I think for me, there's a saying in Nigeria, the people that wears the shoe know where it pinches. And I think, one of the big takeaways for me in terms of this conversation is whoever you listen to, that really resonates in terms of their understanding of the local context and being able to have the solutions to what they're experiencing. And related to that, we've got a few points that we've created ahead of this conversation. But I think out of all this, there's also some other insights that have come out. But I just want to go through the call to action right now. We have 5. One is around prioritization of resourcing local organizations. Second is forming collaborative funding partnerships. We heard from a number of the panelists about the importance of collaborating together. The example between every pregnancy and Axmed is a good example of that. Investing in ecosystems efficiency, I think again something that Sanjana brought up just now. And then alignment with government's priorities from a transparency perspective. We heard from Honorable Harriet why this is so important. We can only do so much with philanthropy unless basically we integrate into system solutions at a government level in collaboration with government and their priorities. Getting to scale is a real challenge. And what we've seen from an Axmed perspective is how we can plug into that to make those systems more efficient. Could be a real game changer. So we want to really encourage that. And last but not least, enabling flexible funding in crisis situations. We've heard from the speakers that basically those on the front line are the ones that are often the first responders. They're the ones that carry the camera most of the time. How do we make sure that enough resources go to them to be able to play that role? So thinking about innovative models in terms of doing that. So those are our first thoughts in terms of call to action. After this, we'll be reaching out to you to try and get further thoughts and insights from you, and then we'll be writing that out over the coming weeks. So please don't be shy. If we reach out to you, we'd love to get a contribution. But once again, I want to thank you all for coming here and kicking off your UNGA with us.